Great. So greetings, everyone. Welcome to the 236th session of the online Optom Learning Series, OOLS. And for today's session, we have with us Dr. Helen Liaw. Helen has obtained her Doctor of Optometry degree from Pennsylvania College of Optometry in the USA and has also an extensive experience in practicing in Canada before she returned back to Taiwan. She helped to set up the RST, the Vision Care Institute in Asia, which is outside of the USA for Johnson & Johnson Vision. She currently practices optometry with an ophthalmology clinic in Taiwan and continues to promote contact lens education during her time which she has. She has helped out as an assistant professor for the Department of Optometry and also been involved in teaching and advocating about contact lenses, I think, worldwide. And she's also been appointed to be the BCLA ambassador for Taiwan region. With that hat, she has planned and executed the BCLA Asia 2022 conference, which was also in conjunction with the Myopia Update Symposium. With the passion she has, she always tries to bring optometry in Taiwan with lines at the international standards. And today, Helen is going to take us through the clinical pearls in myopia management or myopia control and give us a landscape about what's happening in Taiwan and how can we put that into our practice in our part of the world. So welcome, Helen, onto our platform. And, let me just leave the screen time to you, please.
Thank you. Thank Fakrudin for the introduction. And good evening, everyone. I'm Helen from Taiwan, and it's a great pleasure. Thank the organization Online Optom Learning Series for the invitation. It's my great pleasure to share my clinical experience with fellow colleagues across the region. So in today's presentation, I will share the landscape of myopia control in Taiwan, some cases to share a few clinical tips on myopia control. According to Impact of Myopia and High Myopia report of the joint WHO PHBI Global Scientific Meeting in 2015, evidence is mounting that myopia is growing around the world. It is estimated that on average, 30% of the world is currently myopic, and by 2050, almost 50% of the population will be myopic, which is about 5 billion people. The quick rising of myopia prevalence is an epidemic issue, and you can see that the USA has reported a prevalence of 42%, almost doubling in 3 decades. The hotspots of myopia in the world are East Asia and Southeast Asia, which has a prevalence of myopia of 80 to 90%. Taiwan is one of the hotspots. And according to the evolution of the prevalence of myopia among Taiwanese school children done by Dr. Zixun Cai of the National Taiwan University, the prevalence of myopia in first-year elementary school was 5.37 in 1983, but increased to 25.41 by 2016. For grade 12 student, it was 72.23 in 1983 and then 88% in 2016. It implies that Taiwan has early onset of myopia and one of the highest prevalence of myopia in the world. You can call it the capital of myopia in the world. Taiwan not only has a high prevalence of myopia, early onset, but also a very fast progression rate. Dr. Chen Jianren was our past vice president and an epidemiologist himself, and he reported back in 1997 that estimated progression rate for children 6 to 15 years old in Taiwan is about 1 diopter a year. And for age 15 to 18, it is about half a diopter. And above 18, it is roughly a quarter a year. At our clinic, our treatment goal is to halt the progression of myopia, so children will not become high myopes. With such a high prevalence of myopia at the present, prevention is possible but difficult. So the realistic goal is to lower the progression rate by 50%, so children have a 90% chance of remaining below -5. Over the years, there are new research evidence and new standard. Dr. Bollamore says for myopia control, each diopter matters. 1 diopter increase in myopia is associated with 67% increase in prevalence of myopic maculopathy. And slowing the myopia by 1 diopter should reduce the likelihood of a patient developing myopia maculopathy by 40%. So that is what we try to do at our clinic. Try to increase the efficacy of myopia control and keep the prescription as low as possible. The key risk factors for myopia include parental myopia, education, and time spent outdoor. According to these factors, Taiwanese kids are at high risk for developing myopia. First of all, after so many years of high prevalence of myopia, it is extremely common for children to have both parents being myopic. With 1 myopic parent, the risk of myopia increased by 2 to 3 times according to different research papers. And with 2 myopic parents, it can increase up to 5 to 6 times. Second, nowadays, with many families have both parents working, children usually need to go for after-school care, most likely extra learning activities. Thus, outdoor time is reduced and educational time is lengthened. The risk for myopia is even higher. It is very common for children in Taiwan to go to after-school tutorials, and we call these private after-school tutorials cram school. This is a photo that I took next to a junior high school, and I marked the private after-school tutorials by a blue arrow. We call cram schools, you can see that within 1 block, all the signboards are cram schools and nothing else in 1 block. Cram schools, you may interpret it as cram more stuff into your brain, and physically it is very crammed as well. Usually the classroom is small and much more crowded than public schools, which follow government standards. Distance to the whiteboard is very close, and unlike public schools with wide corridors, fields, and open space, these cram schools are usually located in older business buildings without open space. So according to a research paper in Taiwan titled "The Association Between Near Visual Acuity and Incident Myopia in Children," a national 4-year follow-up study done by Dr. Bo Wen-Hu, Taiwan children attending cram school for more than 2 hours a day has a 30% higher chance of developing myopia. It is because of the increased near work in the limited space and decreased outdoor time. Education is an important risk factor for myopia. The educational system can also play a very important role in myopia control. In Taiwan, from 1980, Taiwan central government started student visual acuity screening done by school nurses for children aged from 6 to 15 in Taiwan. Students with uncorrected visual acuity of 20/25 or worse in any eye would require a referral to the ophthalmology clinic. The strategy for myopia control done by the educational system at school changes over time. From 1999 to 2007, the strategy for myopia prevention include improving classroom lighting, adjusting table heights, encouraging gazing into the distance, promoting near work breaks, and encouraging eye exercises. However, it didn't seem to work much. So from year 2007 to 2009, the Ministry of Education established a new program. During the Vision Care Advisory Council meeting within the Ministry of Education in 2009, Professor PSPHOO proposed that outdoor activities should be promoted as a priority to reduce the prevalence of myopia, following a scientific evidence-based researches. So the Ministry of Education took this advice and subsequently established a 10-10-120 program, which promotes outdoor activities for 120 minutes every day, and it was added as the most important strategy for myopia prevention starting from September 2010. After the implementation of this outdoor program, the prevalence decreased continuously from 49.4% in 2012 to 46.1% in 2015. So, policy intervention to promote increased outdoor time in schools seems to reverse the long-term trend of increased visual acuity reduction in school children in Taiwan, according to Professor PSPHOO. So there might be hope. Myopia, especially high myopia, increases the risk of blinding diseases, including cataract, glaucoma, retinal detachment, and myopic maculopathy. For example, for myopic maculopathy at -8, the risk is 121 times greater. Due to its complications, myopia is classified as a disease in Taiwan, and this classification has its implications in both the eye care professional scope of practice and the treatment options available. Because it is classified as a disease, and only medical doctors are allowed to diagnose and treat diseases, myopia control is mainly practiced by ophthalmologists in Taiwan. We have a society named Taiwan Myopia Disease Society dedicated to promote myopia professional education in Taiwan. Our optometrists and opticians cannot serve kids under 6-year-old, and kids 6 to 15 years old, they can only fit glasses, mainly for myopia correction. And they cannot fit products that claim myopia control effects. So myopia is considered as a medically necessary treatment in Taiwan, and we have all 4 options, including atropine, ortho-K, soft contact lenses, and spectacle available. Atropine is the most common method, which has been used for at least 30 years. Our National Taiwan University, Dr. Luke Lin Rongguang, and Dr. Shi Yongfeng were pioneer researchers in this area, and their strong scientific evidence has promoted the wide use of atropine in Taiwan. In the past, high concentration atropine was widely used, but within the recent years, the trend has updated to focus more on low concentration atropine. And due to the high cost of doing a local clinical trial for product registration, we have limited ortho-K brands, with probably the top 2 brands dominate most of the market. Soft contact lens is a growing category for myopia control, and international brand is the leader for sure. As for spectacle lenses, we do have major brands available in Taiwan. with leading brands and several smaller lens manufacturers are joining in. For the repeated low-level red light therapy, leveraging the therapeutic property of red light within the visible spectrum to influence ocular growth, it is not yet available in Taiwan. Now, with the understanding of the myopia control landscape in Taiwan and the treatment options available, I will start to share some case. The first case I would like to share is nearsighted, yet not nearsighted. In October 2022, there was a 5-year-old boy came to our clinic for vision testing because he failed school screening. He was told by the previous clinic that the boy is nearsighted, yet not nearsighted. So the parents were confused and they came for second opinion. The boy has long school hours till 5 p.m. until the parents are off from work, and both parents are myopic. With cycloplegic refraction, it revealed that the kid has only about plus 50 in the right eye and plus 0.25 in the left eye. With this information, what would you do as an eye care professional? There is certainly no right or wrong answer. Each CP might do it differently, but let me share our experience. In our clinic, we would define this patient as pre-myopic and treatment intervention is needed. By International Myopia Institute's definition, pre-myopia is a relative state of an eye with less than plus 7.5 hyperopia or less than half a diopter myopia in children where a combination of baseline refraction, age, and other quantifiable risk factors provide sufficient likelihood of the future development of myopia to merit preventative interventions. And we can identify a pre-myope by family history, refractive error, visual environment, binocular vision, ethnicity, and the living environment, such as urban versus rural. So according to the International Myopia Institute's definition, the ophthalmologist in our clinic diagnosed this patient as pre-myope and started the intervention. First of all, we explained to the parent that we would expect the child to have at least more than plus 1 diopter hyperopia for his age. So currently, he had less than plus 1, nearly plus 50 only at the most. So we consider him to be relatively more myopic for his age. And with this little amount of hyperopia left, there's a 90% chance that the kid will become myopic next year, according to research. So we encourage him for outdoor activity of 120 minutes a day and frequent breaks of meal work. And the doctor started him with 0.1% atropine and follow up in 1 month to see how he's doing. In January 2023, the child, not yet 6 years old, has barely any hyperopia left. Thus, at the follow-up visit, we increased the concentration to 0.02%. And then by March, with more relaxed accommodation, hyperopia seems to come back by a little bit. And since then, we monitor the boy for over a year now. And the boy is doing well, is fairly stable, but still a very gradual decrease in hyperopia over time. So it warrants close attention to see his future development. And with this case, I would like to share a message that myopia control conversation with parents don't start with minus. We should be more proactive, and the myopia control conversation with parents should be on routine basis once they start their routine vision testing in kindergarten. So atropine is the most common intervention in Taiwan, and many pre-myopes are very young and they are already starting to use eye drops. In clinical practice, it is important for us to distinguish a poor responder to atropine versus a non-compliant patient. Young kids, especially Asian, have tight lids, and sometimes kids are afraid of using eye drops. They might cry, or they might even wash out the eye drops, tear a lot. So at our clinic, it is very important for us to check if the eye drops are instilled properly. We will check if the pupil is dilated. Even though pupil size does not correlate with efficacy of atropine, but it is a way for us to check if the eye drops got in. For kids on atropine, they already have the eye drops at home. So we ask them to put 3 drops 10 minutes apart, 1 hour before coming to our clinic. And once arrived, dilation should have happened. Besides doing the cycloplegic autorefraction at clinic to monitor the refractive error, we would check the pupil size to see if it is dilated. If it is not quite dilated, then we might suspect the drops didn't get in properly. And we'll ask questions like, who did the drops? Is the kid afraid? Did the kid cry? Did the kid tear? Sometimes we will instill the eye drops at our clinic to see if the kids tear a lot and wash out. And instructions about how to put eye drop for kids is very important. This chart is a good reference to know how much pupil is dilated by different concentration of atropine. 0.1% has 1 millimeter increase in pupil size, and 0.05% has about 2 millimeter increase in pupil size. So atropine is usually done once daily before bed, and we would share some tips about how to instill eye drops with parents. First, we would remind parents to wash their hands properly before handling eye drops. Second, we would usually try the usual sit-up method to pour the lower eyelid and see if it works. We encourage kids to cooperate by letting them know the eye drop might cause some discomfort. It might sting a little bit, but it's for good cause to prevent the eyesight from getting worse. And if it succeeds, then we will give the child some reward. And if the usual sit-up method doesn't work, then maybe reclining on a pillow or lying on the mother's lap might be a good idea to give the child some support at the back and pull the lower lid down as usual. If nothing works, maybe we can consider using the eye drop when the kid is sound asleep, or we can instill the eye drop on the medial canthus without kids opening their eyes. Okay, so this is a short video for me to show parents for young toddlers who cannot tolerate the eye drops, who are afraid of seeing the eye drops coming in. This might be an alternative method. We can put the eye drops on the medial canthus with the eyes closed, and then ask the kid to open their eyes, and the drops usually get in successfully. This is our last alternative method. Okay. And according to different research, next I would like to share some cases on anisometropia. And according to different research papers, anisometropia in children from infancy to 15 years old, the prevalence of anisometropia is relatively high during early infancy and then decreases by some extent during the early age of life, followed by an increase from age 5 to 15. Besides an increase of prevalence of anisometropia during school age, the extent of anisometropia also increased. I think it is a significant issue for clinicians to pay attention to while doing myopia control for anisometropic patients. Besides slowing down the myopia progression, we should try to halt the amount of anisometropia if possible. There are few clinical issues with anisometropic patients. First of all, it often happens that unilateral myopes have one good eye without refractive error and they see fine. Thus, they often don't see the need for vision correction or they are less concerned about myopia control. Second is that when they wear glasses, they often feel dizzy due to anisoconia. Thus, they may not like wearing glasses. As for myopia control, contact lens is certainly the better option due to better optical quality. And the latest evidence shows that the rate of axial length increase with ortho-K treatment is significantly slower than the non-treated contralateral eye. According to the effect of ortho-K on axial length growth in myopic anisometropes done by Dr. Chen Zi in Shanghai. In his research in part 1, the rate of axial length elongation in the ortho-K treated eye was significantly slower than the contralateral eye. In part 2, the rate of axial length elongation after ortho-K treatment in the newly developed myopic eye was significantly slower than before ortho-K treatment in the same eye. So in conclusion, ortho-K treatment slows axial length growth in the more myopic eye, and should the contralateral eye develops myopia in the future, ortho-K is capable of slowing down axial length growth in that eye as well. And at the present stage, we don't see this kind of evidence with 0.01% atropine or daily soft contact lenses for myopia control. So among the 4 options for myopia control, there seems to be an advantage for using ortho-K for anisometropic patients. Let me share an anisometropic case with you. An 8-year-old girl first came to our clinic in September 2021, and she needs new glasses. Our examination result revealed that her hyperopia is already less than her old glasses from 2 years ago. Thus, she needs an update on prescription. And since it is already plano in the left eye, we encourage more outdoor time to prevent myopia. And in March 2022, she came back and her hyperopia in the right eye is fading fast, but left eye is still stable and roughly plano. By March 2023, her right eye hyperopia is fading and left eye is becoming myopic. Thus, the doctor put her on 0.01% atropine and asked her to come back in 2 weeks. According to our record, she did not show up until December, quite a few months after. We asked her, why didn't she come back? Why did she miss the appointment? The mother replies that she thought her kid's eye were in the best shape, that her hyperopia was finally fading away and nearly ametropic, and the child can see fine without glasses, until recently that the child starts seeing a little bit blurry again. On that visit, left eye is becoming myopic at -1 already. And when she follows up in March 2024, it is still myopic in the left eye. Well, what do you think? Or what would you do? Obviously, she has myopia in her left eye and has roughly almost 2 diopter of anisometropia, and something needs to be done. So we gave her the Myopia Control pamphlets for her to consider the different options, and we advised her for OOLS, better for visual quality, and also soft contact lens for myopia control doesn't have astigmatism prescription for the left eye. So the patient came back in April for consultation, and she prefers OOLS. For OOLS, there are computer-assisted fitting, trial lens fitting, and empirical fitting. There is certainly an advantage of having a trial lens on site. We did a trial for the girl to feel it and make sure that she can take the foreign body sensation of a hard lens. So trial lens at this stage serve as a good tool for patient selection. And in May, we fitted her with OOLS. And besides doing the routine OOLS fitting, we assessed the binocular vision and we did the stereopsis test. We did stereopsis with naked eye, with trial frame, and also after the patient started wearing OOLS. An improvement in stereopsis is expected, but parents were very happy that they see the binocular vision improved after wearing OOLS. So there are 2 key learnings from this case. First of all, when patients with significant refractive error, they take it as children has a vision problem and they need to be taken care of. Thus, they think it's important to see a doctor. However, when the refractive error decreases and is nearly ametropic, sometimes the parents will be less compliant. They didn't see the problem existing. And they didn't think it's important to see a doctor until the child became myopic with a significant amount and vision was affected. So as professional, we did see the problem coming and prescribe atropine. Unfortunately, the parents didn't understand. So it reminds us that clear patient communication is very important. And second, trial lens can serve as a tool for OOLS patient selection as well. And third, seeing is believing. With anisometropia, contact lens serve as a better option, and we do several different kinds of binocular vision tests. But those binocular vision tests might be difficult for parents to understand. And the easiest is do the stereopsis, for example, titmus with fly or butterfly. And we do it before and after. And the patient and the parents can see the difference and it enhances patient satisfaction. Okay. Let me do a third case. A 5-year boy first came to our clinic in June 2017 and diagnosed with amblyopia in the right eye due to high astigmatism. We fitted glasses and started amblyopic treatment, and visual acuity improved greatly. By end of 2020, the eye becoming myopic and we started on atropine. And while the right eye with hyperopia and astigmatism remains stable, the left eye, myopic eye, progressed fast. From 2020 October to 2021 August. And we recommended outdoor time plus atropine. For 2021 and 2022, 0.03% atropine seems to work very well. And up to September 2023, it is already minus 1.75 in the left eye, with a slight increase of half a diopter in 1 year, which is acceptable. However, the anisometropia gap is getting bigger, and mom is highly concerned and wants to be more aggressive with treatment. So what would you do? It is good that the mom is fully compliant and vigilant. So in February, the child was fitted with OOLS for the left eye. And due to the high astigmatism, so he still needs to wear glasses during the daytime for the right eye. And because of the low hyperopia reserve left, we kept him on 0.03 atropine for a while. If possible, we'll save 1 diopter amount of hyperopia until age 12 is much safer to prevent myopia. So this is a very complicated case. Life doesn't seem easy. Okay, so this kid has OOLS plus glasses plus atropine. Okay, and the next case is about anisometropia again, but this is a case that the child prefers myopia control glasses. So a 6-year-old boy first came to our clinic in October 2018 with small amount of refractive error. And due to myopia in the left eye, 2 weeks follow left eye, we prescribed atropine. And however, the patient was not quite compliant, no follow-ups. And by 2019 September, left eye was already -1 and progressing fast. By December, it was already 150, and glasses was prescribed. And unfortunately, patient didn't continue to use eye drops. By the time he come back in March 2020, it was already -2. What should we do? We recommended the contact lens option for the patient and the parents. And at this point, let me share how contact lens for myopia control is perceived in Asia. It might be a little bit different from the rest of the region. According to a research paper from Hong Kong, parents choose contact lens as myopia control option due to convenience, especially OOLS. There's no contact lens at all during daytime. And parents don't choose OOLS due to concerns about eye movement during sleep, rubbing eyes while sleeping, difficulty of lens insertion and removal. And parents don't like daily disposable for myopia control due to lack of parental supervision. So in America, children are taught to be very independent. Usually it's the child himself handling the contact lens. However, in Asia, parents are much more involved in OOLS. They don't consider it just as ordinary contact lens. They think the child is under treatment, and usually for a child, especially in elementary school, usually it is the parents doing that lens insertion, removal, and cleaning. So for that case, we discussed. The parents had concerns about children wearing contact lens. They prefer their child not to wear contact lens, including OOLS or daily disposable. So it was against our recommendation. However, discussing with the parents, we respect their opinion, and then we fitted the child with peripheral defocus honeycomb design myopia control spectacle lenses. And we follow him up regularly. And after almost 3 years, The prescription was very stable. The lenses were scratched and needs replacement, and that's what we did. So for this case, my learning that the best treatment for the patient is the treatment that's agreed by the parents and the eye care professional and the child. It shouldn't be based on efficacy alone. And sometimes the parents understand their kids the best. And let me talk a little bit more about contact lens compliance. The common ortho-K compliance issues in my clinic include patient might not change lens case or replace lenses on regular schedule. And what we do is, first of all, as I said before, in Asia, usually ortho-K lens handling is handled by parents. So for the pickup session, we would invite both parents to attend to make sure they have adequate knowledge of ortho-K. Second, besides educating during the pickup session, we remind them one thing at a time at each follow-up visit. Don't expect patients to understand everything all at once. And education is the best way to enhance patient compliance. Besides oral communication, we leverage different tools to facilitate delivering the messages. We will play videos in the waiting area and put these videos on our clinic FB as well. Okay. Let me share an extreme case about lens replacement. Okay. On May 8th, I received a phone call from a patient who insisted that her son was fitted with ortho-K at our clinic, and one lens is broken and needs replacement. We cannot find the patient's medical record. Usually, medical record paper version is kept for 7 years, which means that patient hasn't been back for more than 7 years. We look up our computer system and found that the last visit was 13 years ago. We were shocked, and we asked the mom for more details. The mother is an RGP wearer for 30 years, and she has never changed lenses on regular basis herself unless there is a problem. She assumes it's the same for her son, and she thinks there's no need to see a doctor unless there is a problem. Thus, there was no follow-ups or lens replacement for her son. Well, what do you think? And what is the ortho-K lens replacement frequency in your country or in your clinic? If I look up Google about clinics in different parts of the world, for example, here, there's one clinic in California, USA, which recommends annual replacement. Another one in Maryland, America, recommends 1 to 2 years. Here in Australia, recommends replacement of at least 1 to 2 years. And in Taiwan, according to the Ophthalmological Society's website, it is roughly 2 years, but it can last up to 3 to 5 years. It seems to be an area that we can work on to be in line with international standard to promote a lens replacement frequency of shorter period. If we look up scientific research papers, for example, this one done by Jesse Charm and Professor Pauline Cho, during their research, lenses is replaced annually. Another one done by Professor Peter Chen Zi in China, they replace it every 12 to 18 months. And this one in Europe, lens is replaced every 12 months. Then, what can I do with stubborn patients who don't change lenses, like that extreme case that never came back for follow-ups? What happens when ortho-K lens ages? And ortho-K lens is more difficult to clean than RGP. So in our clinic, we do a campaign. Usually, we do organize an activity during school break, for example, summer vacation, to encourage less compliant patients to come back for follow-ups. We give them extra incentives. We ask the ortho K company for support, and they will provide manpower and equipment to come to our clinic to check the lenses. And patients who participate in this activity will get an extra solution kit. And the ortho K company sales rep will bring their equipment with magnifying glasses and to show the parents the photo of their lenses. Also to educate them about protein deposit and scratches. So seeing is believing. Lens check is routinely done by slit lamp, but that might increase your chair time. So we organize this activity with support from the ortho K company to use other equipments available and which technical assistants can do as well. And this may be a good way to save time. So this is what they do. I asked them to put a video using the 78 diopter, which is easily available within the clinic, or you might have extra ones. So they use iPhone and the 78 diopter, and they put the lens on top. And it shows the protein deposits. Okay, so your ortho K company can be a great help as well, great support to help us educate the patients, and seeing is believing. Another common compliance issue that I have faced before is sometimes patient will ask me for a flat case when ortho K solutions comes with cylindrical case. We all know that cylindrical case reduce the chance of contamination due to small openings, less area to be contaminated by fingers. But we have patients ask us for flat case so they can decide on how much solution to add in and they can save more money. So for this kind of patients, we need to reiterate the reason for cylindrical case and to recommend monthly replacement of lens case to avoid biofilm buildup. And next one is a suction holder. Suction holder is a very convenient tool for lens removal, and it is widely available. And most ortho K patients use suction holders here in Taiwan. But at our clinic, we follow Professor Pauline Cho's teaching. If we can use as little accessories as possible, we can reduce the chance of accessory being contaminated and then cause inflammation or infection of the eye. So we teach our patients to remove the lenses without suction holders.
接下来呢，我们会用右手中指固定镜片的下方，左手中指呢就透过上眼皮的挤压取出镜片。
Okay, so overall, in our clinic, we spend a lot of effort on myopia. For a patient, myopia is a lifelong journey. As kids, we start with myopia prevention, and at school age, we do myopia control. For young adults, we do myopia correction by contact lenses, or for example, anti-fatigue lenses, and we treat contact lens complications, etc. Later on in adult life, we manage myopia disease. So for me, I think myopia management is the core of family eye care, and it is worth your while to start the myopia control practice. And that will be my presentation for today. And thank you all for your attention.
Thank you so much, Dr. Helen, for that wonderful presentation. I think you did give us a lot of tips when it comes to, monitoring patients, looking at the binocular vision status and examining of the lens as well plays an integral role in, myopia management, contact lens clinic and all of that. So thank you so much for, sharing that with us today. Okay, there we go. So I think the most important part of doing myopia management is to make sure that kids don't land up into high myopia. And we do want to talk about outdoor activities to have a preventive role as well. So one of the question here is asking about nowadays kids usually have a lot of digital time to either by doing their school homeworks, doing their other hobbies and things like that. Would you give us some tips on how do you communicate the importance of outdoor activities to kids? Any tips or any thoughts which you can share with us? What do you do in your practice?
It is a very big problem here in Taiwan. When I talk to patients and parents, it is very, very difficult to encourage kids to go outdoor. So what we do in Taiwan is we make the outdoor time into the school educational system. So as you can see in my presentation, that now we encourage all kids to go outside the classroom during recess. And if we add all those times up, they can have at least 80 minutes a day. Okay. So this is kind of like an idea from the American education system that they lock the door so kids cannot stay indoor during recess. So that's where the idea came from. And so here in Taiwan, we try to implement this outdoor time mostly within the educational system. And it is possible. We think that by implementing this strategy, it is possible to reverse the trend of increased myopia prevalence. So understand, and I fully agree, it is extremely difficult to encourage kids to go outdoors. So we put it into an education system and with a strategy.
Yeah, I think myopia management is not just the optometrist's job, but public health system, teachers and parents, everybody needs to get involved into, doing myopia management. I mean, we can do the best option for them, spectacles, contact lenses, atropine in combination, but then a lot of other things are required to play along as well, right? Yeah.
Yes.
Awesome, great. The other question was, I think you did talk a little bit about the pre-myopia, and one of the case was also pre-myopia as well. What do you think about using low-dose atropine in pre-myopes? How can you justify in terms of the normal development, or probably how can you justify to the parents on how or why do they want to use a low-dose atropine? So, any thoughts on that?
Yes. The first line of pre-myopia intervention is to increase outdoor time and frequent near work breaks. However, we will assess how much the kid is at risk. For example, at age 5 with nearly plano, that is at high risk because the age is very young. So Taiwan, with the history of using atropine for 30 years, it is very common for practitioners here to put kids on low concentration, especially 0.01 is the lowest concentration of atropine available. So each country is a little bit different, but atropine is the most common treatment here in Taiwan because it is covered by mostly covered by national health insurance. So that's the most cost-effective method for patients here in Taiwan.
Yeah, great. I think that also helps because, the cost effectiveness is also something which parents would be worried and plus definitely worried about the drug usage and all that. So I think proper education plays an important role together as well. Yeah. Okay, we'll take a few more questions here, Dr. Helen. This is regarding a few cases which you shared with us today. In the first case, I think you did show us that the patient really came for regular follow-ups and, you did a cycloplegic refraction. Probably somebody wants to know is how would be difficult for the patient perspective to undergo cycloplegic refractions and having these O50 all the time. So probably on the way of communicating to the parents, what do you use any strategy to talk to the parents?
Okay, yes. So cycloplegic refraction usually it's done like minimally twice a year. It's recommended in Taiwan. And depends for kids who are at higher risk, if we want to monitor it accurately, to compare the data scientifically to see if there's any increase, then the data has to be consistent. So for that case, it was a very young boy, so 5 years old, and the accommodation is very high, and since he is already at high risk, the doctor do a cycloplegic refraction. And since he was already on atropine and he has the bottle at home, it is not too difficult to convince the parents that if they use the eye drops at home before coming to our clinic, it actually saves them more time. So the compliance in that part is better than if we do the cycloplegic in our clinic. Because once we add the drops in, they have to wait here for 30 minutes. But if they do it before they come, when they come, they can just do the examination, saves them more time.
Yeah.
So we don't have too much of an issue with that part. And with so many different intervention options available now, kids atropine is not the only option, but for very low hyperopia reserve, they cannot start on any other option at that stage.
Right. Yeah. And I think this is regarding the second case which you shared with us. We did see that in a couple of visits, in the last visit, the patient was already an E-metro with some cylindrical values. So would you add on ortho-K for toric or would you actually give them spectacles? I think you were talking about the combinations and things like that.
Yes.
So would that be an option for doing a toric ortho-K? Do you think the toric ortho-K works for this kind of refractive statuses and things like that? Yeah.
In case 2, I think that just depends on the corneal astigmatism, depends on if it's lenticular or corneal. But I remember case 2 is high anisometrope, and the cylindrical is -3. And so I think that's the case that we put ortho-K in one eye and then glasses for the high cylinder and the other eye.
Yeah.
So
yeah.
Yeah. But basically depends on the corneal astigmatism.
Right. Yeah. So if it was corneal, probably you would have done the ortho-K, and things would have been much better and more independent for the patient, I believe. Yeah.
Okay.
Awesome. Great. We'll take one more last question. This is talking about, I'm not sure if you have experienced this, but somebody might have experienced that when it comes to patients with low dose atropine, they have good compliance, but usually they are good responders in one of the eye, but not a good responder on the other eye. Have you experienced this in your patients? And if yes, what do you think could be the reason and how can we help this?
So if I have a case like that, usually the first step we would do is to ask the parents, which eye do they instill the eye drop first, right eye or left eye? And then we will check which eye is a poor responder. And maybe we'll ask them to switch the sequence. Then start with the poor responding eye and then the good responding eye to see if there's if it makes any difference. Yeah. That's one possible reason, is sometimes they instill the eye drop differently between two eyes. So that's what we usually do as a first action. And after that, sometimes the doctor would assess to see, yes, basically unequal pupil size. Then the doctor will see what he would like to do, or maybe increase the concentration or switch to other options.
Yeah, I think if you put on the right side, always the kid is already not comfortable. So when you're putting on the left side, they are not opening the eyes or the drop didn't went in. So I think that's a very good point to observe and ask patient and probably alternate. One day start with right eye, the other day start with left eye or something like that to see if that helps in the the effectiveness of the treatment option. So if they're compliant, yes, they are putting in the drops, but are they going in is another question, right?
Yeah.
Yeah. Awesome, great. So I think with that, we've taken almost all the questions which popped up on the chat. Thank you so much once again for sharing the Taiwan landscape, and also not only the Taiwan landscape, but you did share us many tips, as I was mentioning earlier, which we can bring to practice from tomorrow onwards to put into the myopia management strategies with our patients. So thank you so much for joining us today.
Okay, thank you.
Yeah, we do have a session planned over the next weekend. Then take care, be safe, and I hope to see you next week. Bye-bye.
Bye-bye.
Bye. Take care.
Okay, thank you.